Hello everyone, today we are going to begin talking about our concept on oxygenation. So our concept is that of oxygenation. We don't have a very specific exemplar or disease process that we'll be focusing on. Our exemplar for oxygenation is principles of oxygenation. So it's a very general topic, and so we'll be covering a lot of different things in this module, but not specifically one disease process. We have other concepts where we have a specific disease process, but not for this one. We keep it very general in this sense. So our objectives for this concept are to describe common assessment procedures and diagnostic tests used to assess the respiratory system across the lifespan, discuss the pathophysiology, etiology, clinical manifestations, risk factors, and causes of alterations in oxygenation, develop interventions used by the healthcare team in providing evidence-based care for the patient with alterations in oxygenation, as well as applying the nursing process to the care of the patients with alterations in oxygenation. And so it's important that we understand exactly what oxygenation is. We're defining oxygenation as the process by which oxygen and carbon dioxide are transported to and out of cells. And so there are several different things that we need to recognize that are requirements for normal oxygenation to occur. We love using that word normal, but what does it mean? For oxygenation, it means we need to have an adequate functioning of our respiratory system with the ability to inhale and exhale with intact lung elasticity and lung expansion. So basically that's to say, we are able to breathe in and out, and that our lungs are able to expand and, what's the opposite of expand? Expand and get smaller so that we can have that inhalation and exhalation occur. We also need to have adequate perfusion for the exchange of gas, of CO2 and oxygen. We need to have functioning perfusion for oxygenation to work. We need to have adequate neurological function, and we also need to have efficient cellular metabolism, including hemoglobin, because hemoglobin is that molecule that carries our oxygen and leads to the exchange of oxygen and carbon dioxide. So in order for oxygenation to occur and to be considered normal, we need to have all of these different requirements working for our patients. A lot of times, there's something wrong with one of these four concepts, and we need to help intervene and get our patient back to this normal oxygenation state. So for our physiological concepts, such as oxygenation, perfusion, tissue integrity, metabolism, the way I structure my lectures is that I follow it through the nursing process. And so we're going to take a look at assessment findings, which include physical assessment, might be including medical history. We might be taking a look at laboratory tests and things like that. And then we'll move on to diagnosis and planning. For each one of our concepts, I like to talk about a couple of nursing diagnoses that are not all inclusive, but are often used with patients who have alterations in that concept. So we'll talk about nursing diagnoses applicable to oxygenation. We'll talk a little bit about planning and goals. We'll make it very general in that sense because we don't have a specific patient we're talking about yet, but I'll talk about those. Then we'll go to implementation and the interventions we use for patients with alterations in oxygenation, many different things, some which you probably already learned about in clinical, as well as evaluation. So this is one of the ways that I like you guys to structure your studying and to structure how you would go about with my lectures is to go through the nursing process. I have devised a chart for you that might help you with kind of organizing your information, or you can make your own chart. But following through this nursing process is very helpful. I'll talk about it again in perfusion, but because we have a more specific disease exemplar, but following the nursing process in aiding your studying will be very, very helpful and help keep you organized. So this video, we're going to cover assessment, and then we'll break up in the other videos into the other topics. So we're going to start with assessment and physical assessment. So just remember that assessment is not just physical assessment. A lot of it can be taken from our patient's medical history. We need to talk to them about that. Some of our patients have differing levels of health. They can have chronic or acute conditions. So chronic meaning long-term issues, or acute ones that have just happened recently. So we need to ask them about their medical history. There are several disease processes that can cause changes in a patient's oxygenation status. Hopefully you're thinking of some of them. Many of them can include asthma. They could include bronchitis, emphysema, COPD. Other things, they could have history of pneumonia that could affect their respiratory status. Another thing that people don't think about a lot is anemia. Anemia can also affect our oxygenation levels because we don't have enough hemoglobin to carry the oxygen. Other chronic disease processes that can affect our patient's respiratory system is obesity. I know I've talked to you guys about how much I love the show, My 600-Pound Life, and a lot of those patients have oxygenation issues like sleep apnea. They need to sleep with a CPAP at night because with their increased weight, that's more weight sitting on their chest, and that's what their lungs have to work against to expand, more weight to lift up to fully expand their lungs and get that inhalation and exhalation. So like I said, a lot of people don't think of obesity with oxygenation issues, but it does relate very much so. Another chronic issue that can relate to oxygenation, which you may or may not have experience with, is stress and anxiety. A lot of times when you're stressed or you're anxious, you breathe more rapidly, you don't take full deep breaths, so it can impact our respiratory system. There's also acute conditions like pneumonia, right? Maybe they have an active respiratory infection. They could be acutely short of breath at a time. They're more chronic ones, like there is like a chronic asthma, right? But they can have an acute asthma attack. But maybe they're having, I don't know, upper respiratory infection, lower respiratory infection, pneumonia. Maybe they have some sort of chest trauma. That would be more of an acute condition. Other things we need to consider when we're speaking with our patients are what medications are they taking. Some of these medications, such as narcotics, can depress the respiratory center of our brain. And so that can actually lower their respiratory rate. So it's something we might need to consider when it comes to our patient's respiratory system. You guys have taken, if you've taken pharm, if you're still in pharm, there are certain autonomic nervous system medications that can impact our bronchioles, whether or not they dilate or constrict. And so we have to think about the effect of those on patients who have respiratory conditions. Other things that we need to consider that we can talk about with our patients are risk factors. Those include smoking, either type of smoking, vapes, or whatever you're smoking. We really shouldn't be inhaling things into our lungs, right? That is a sterile area that we're trying to keep clean. Allergens, any type of pollen or anything like that, as well as pollution. Pollution is a big thing that we talk about here in Southern California with the smog, right? You can see how bad it gets, and that's all going into our lungs. And you need to consider, think about with pollution, it's patients in more urban areas, they tend to have more respiratory issues as opposed to patients in more rural areas. Another thing to consider is patients and their work. In their occupation, are they constantly exposed to respiratory pollutants? For example, painters, also like people who work in construction are exposed to a lot of inhalants. Maybe they work in factories where they're exposed to inhalants. So it's important that we consider those aspects in our patient's respiratory assessment. Okay, so now we're going to talk about the physical examination of our patient. So we're going to go through the 4 different steps of physical examination, which includes inspection, percussion, palpation, and auscultation. So inspection means we're just taking a look with our eyes. What can we see with our patients? So we're going to start with our patient's general appearance. Are they in any distress? Typically, somebody who's having respiratory issues will be showing signs of distress. And so that's something that you can observe by looking at your patient. You're also going to take a look at your patient's level of consciousness. Are they awake? Are they alert? Are they drowsy? Are they obtunded, meaning it's very difficult to wake them up? Are they unarousable? So it's an altered level of consciousness there. So you can go ahead and observe that with your patients. Do they look you in the eye? Are they able to answer your questions? Assessing your patient's level of consciousness does play a lot into your patient's respiratory status and whether or not their brain is getting enough oxygen. Pallor or cyanosis. Pallor is the paleness, right? And you can see that in a patient's skin. You can see that in their mucous membranes, and it typically indicates some sort of perfusion or oxygenation issue. So you could take a look. You can see that in your patient's skin. Sometimes you could see it in their mucous membranes when you look in their conjunctiva, in their oral cavity. You'll see that they are pale. Okay. Oftentimes you can compare it to other parts of the skin so you could see whether or not they are changes in color. It could be one hand and be pale and one hand not be pale. And then there's also cyanosis. Cyanosis is a bluish discoloration of our patients, and they can be separated into peripheral or central. So I do have some pictures here that I've added to these slides. So this right here is pallor. I know it's not the best picture, but you can see that this hand is a little bit more red, a little bit more pink than this hand. And so this would be pallor. I guess on this person, like left-handed pallor. This here would be cyanosis. We would classify this as peripheral cyanosis, meaning it's happening in the outer parts of their extremities. So in their fingertips and the toes, patients can experience this purplish, bluish discoloration. That's because it's having a perfusion or oxygenation issue to those distal areas of the body. While this is pretty dangerous, the more dangerous type of cyanosis is central cyanosis. And that appears more here in their mouth, in their oral mucosa. You can see that they have, they're having oxygenation and perfusion issues more in their core. So that's a more emergency because of the fact that what happens is that with your body, you have this peripheral cyanosis. It starts shunting blood and oxygen to your core. Okay, it's saying your core vital organs need oxygen more. But when you're starting to show central cyanosis, it's like, okay, we cannot compensate anymore. And we're starting to have to really just shift to your heart and lungs. And that's all we can essentially provide oxygen to. So this is an example of pallor. This is an example of peripheral cyanosis, and this is central cyanosis. So this is talking about discoloration in pale skin individuals. There is a book that I've put under your resources that it's actual book that they've been working on developing, and it's talking about skin color changes and skin conditions that you would see in people of darker skin, and it's called Mind the Gap. So in that book, there is a picture of someone who has cyanosis as well as central cyanosis in darker skin individuals and how you would be able to assess that. So they are working on developing this book, and I have linked it in your resources if you want to go ahead and check that out, because we need to still be able to assess cyanosis in our individuals who have a skin other than this pale white skin. Okay, let's go back. Oops. So that is pallor or cyanosis. Oh, another issue that we can have with our patients on this slide is that of clubbing. And I'm not talking about the cool new club to go to, you young people go to. I'm talking about clubbing of the fingers. And what that is right here. You can see that this is what a normal, if you put your fingers together like this, they should meet. And you just have a little small window here. But patients who have clubbing of the fingers, their nails tend to club downwards, they curve downwards, and they're not able to have that little window. So it kind of looks like this, okay? And patients who have clubbing that we can see on their fingernails, it tends to be the result of a patient who has long-term oxygenation issues. Oxygenation and cardiac issues. So I'm not exactly sure what changes, but the structure of their nails do change and have this clubbing formation, and you can see that on your patient's hand. So if you see and assess your patient's hands, you're looking at them and you see they have clubbing, it should all trigger to your mind that they've had some sort of cardiac or oxygenation chronic issue that's led to the formation of their fingers in this clubbing shape. My best friend, she does have, she had a hole in her heart when she was a kid, didn't get fixed till she was much older, and so her fingers, she did have this clubbing like in this photo that is indicated here. Other things that we can see include the structure of our patient's chest. And so when we take a look at the structure of a patient's chest, we're going to take a look at their anterior, posterior, transverse diameter. And so I'm going to show you a photo here. And so this is what we're talking about. You can see right here. There is the anterior, posterior diameter versus their transverse diameter. Okay, so front to back, side to side. So a normal adult should have a anterior posterior diameter, front to back, that is half of their side to side diameter. Okay, so a normal one is this one here. You can see it's about a ratio of 1 to 2. That is considered a normal chest diameter for adults. Some of our patients who have emphysema, which is a chronic oxygenation issue, tend to become more barrel-chested. It's a chronic issue. They don't develop this kind of chest overnight, but they're barrel-chested, meaning their anterior posterior diameter is equal to their transverse diameter. And once you learn about emphysema, you'll know that there's a lot. The alveoli sacs, they don't become little grapes anymore. They become like bigger things, and they take up more space and leads to this barrel chest formation. But if you see a patient who has a barrel chest where their anterior posterior diameter is equal to that of their transverse diameter, then it's another signal to you that your patient may have some chronic oxygenation issues. Another thing that you could see in some patients is kyphosis, which we see a lot in our older adults, which is this curvature of their top of their neck, thoracic, cervical spine here, right? It tends to curve downwards. They tend to get a little bit more hunchback. And that curvature impacts the way that your patient can fully extend and fully breathe. And so it's important that you examine your patient and see whether or not they're experiencing any changes to their structure of their chest. Another thing that we can see with our patients is their respiratory rate, their rhythm and depth. So we know that a normal respiratory rate is between 12 to 20 breaths per minute. That's the normal respiratory rate. If they're breathing faster than that, it's called tachypnea, meaning it's a respiratory rate higher than 20. If they're breathing slower than that, that is a respiratory rate less than 12, it's bradypnea. There is a difference, just to tell you, between tachypnea, which is rapid breathing, and hyperventilation. Hyperventilation is an increased rate and depth, whereas tachypnea is just about the increased rate. Normal breath depth for patients, normal depth is they are able to intake full deep breaths. Okay, so full deep breaths are considered a normal depth. You can have patients who have shallow breathing. That would be an abnormal finding. And then we can talk about your rhythm. And there's many different rhythms that we'll talk about on the next slide. Other terms that you should know about is orthopnea, which is difficulty breathing when you're completely flat. That means that patients oftentimes have to sit up in that tripod position. There's also dyspnea, meaning they're having just difficulty breathing, or difficulty breathing, shortness of breath. Other terms you need to know are apnea, meaning they've stopped breathing completely, which is not good. So other things that we need to know are the respiratory rhythm, right? Rhythm is looking at how and looking at the pace of their breathing. So I have a slide on that. So here we have a little bit of normal breathing. Eupnea is normal breathing rate and pattern. Tachypnea, remember we talked about that as an increased respiratory rate, and that can be caused by fever, anxiety, exercise, and shock. Again, a respiratory rate above 20. Bradypnea, which is a decreased respiratory rate or a respiratory rate less than 12, could be caused by a patient sleeping, medications, metabolic disorder, head injury, or stroke. Apnea, remember we said that is the absence of breathing. Hyperpnea is a normal rate, but they're taking deep respirations, okay? So you just breathing normal, right? That's a normal depth. But if you're breathing at that normal rate and you're breathing very deeply, but at a normal rate, like taking your lung sounds and you're doing that all the time, you would be calling that hyperpnea. That could be due to emotional stress and diabetic ketoacidosis. And then we have a couple of other breathing patterns here that are abnormal. That is Cheyne-Stokes, we have, which are gradual increases and decreases in respirations with periods of apnea. Biots, which is rapid, deep respirations with short pauses between sets. Kussmaul's, which is tachypnea and hyperpnea, and apnoistic. So you have different causes there. I thought it was important that you guys just know what these different types of respiratory rates are. And the thing is that I actually have them, so get out of this, under your oxygenation resources, I have a video which talks about the different breathing patterns, and they do have actual recordings so you can hear what those breathing patterns sound like. So I do also have a video that I'll show you here of some Cheyne-Stokes and Kussmaul's breathing patterns. Let's hope that it works. So you can see that this patient is getting shallow with their breathing, and then it's starting to get deeper and rapid, and then it's going to start to slow down and slow down in depth, and then it's going to stop. So you should be taking a look at their, look again. Increase in rate and depth. This is Cheyne-Stokes. Increase in rate and depth and pace. Then it's going to start slowing down in rate and depth. And they'll have a period of apnea. And then they'll do it all over again. So this is Cheyne-Stokes. You can see it. Let me see if I can go back. No, let me go back. That is this type of breathing right here, Cheyne-Stokes. Gradual increases and decreases in respirations with periods of apnea. Okay. The other video on this is Kussmaul's breathing, and that is that tachypnea and hyperpnea, which we often see with patients who are in some sort of acidotic state. So here, let me show you. They are taking, they have rapid breathing, and it's very deep, rapid breathing. Okay, so let me show you here. I gotta skip some. He's taking rapid, deep breaths. There's not really changes into the depth level of his breathing. He's in diabetic ketoacidosis. You can watch the whole video if you want, but you can see, again, rapid, deep breaths, as opposed to the other video where it was gradually getting deeper. He needs to breathe off that acid, which is just CO2. So this poor little guy is in Kusma breathing. Okay. I believe the other slide here talks about BIATS, and that is available in this breathing patterns video here. Okay. So make sure you check out the resources for these different breathing patterns. I'm not going to ask you, specifically to exact causes of them, but it is important to be able to, recognize different types of breathing patterns to know what's normal and what's abnormal. Okay. Let me get on. Okay, so this talks about some of the changes in breathing and respiratory structures as patients progress through life. You could see here with our older adults, this is a typical respiratory rate. They do tend to be more chest breathers as opposed to children, which are big abdominal breathers. Older adults have thin, prominent structures. Lung sound should be clear. They can be barrel-shaped, or typically they're more elliptical. There is a table in your book. I believe it's the chapter on oxygenation and perfusion in your fundamentals book that discusses specifically the age-related changes that happen to our older adult. Our class focuses on older adults, and so that we did have that older adult assessment. But it's important to remember that there are these changes that happen in our older adult, not just in their structure, but they also have decreased gas exchange. They have an increased work of breathing. They do have the reduction in their vital capacity of their lungs. They do have that ineffective cough. They have drier mucous membranes and are at greater risk for aspiration. So it's important to recognize the changes that happen in our older adults. And again, there is a book in there is a chart in your Taylor's fundamental book under the oxygenation and perfusion chapter that I think you should reference and read, because it talks about those age-related changes as well as the strategies that we do as a nurse to help our older patients with these changes. Okay, so palpation is another technique that we do. We talked about inspection. Those were all the things that we see. Oh, I don't think we talked about respiratory accessory muscles. Let me go back. We talked about depth, and then the use of accessory muscles. We have accessory muscles. Patients who use accessory muscles, that means that they're really working hard. They're using those other muscles to help them get oxygen into their lungs. And so I have a couple of links on this slide that show you guys about use of accessory muscles. I'll play this one. Hopefully it pops up. It's a little kid. You can see he has some nasal flaring. Do you see his nostrils flaring because it's trying to get more oxygen in? And you can see here that he has some subcostal below his ribs that they are retracting into his chest because that's how hard he needs to work for his oxygen. There's another example here where you can see that they're using their above their rib cage, just like their sternum, mastoid or something. You can see how hard he's working, his body is working. He needs to use these extra muscles in order for his body to get oxygen in there. They're having to use the accessory muscles, and that's something you will be able to observe. Do you see that? You could even see a little bit here. Sometimes you see it in children, especially. There's a tracheal tug where you can literally see them take it, like they're having to breathe really hard, and you can see a tracheal tug there. So that's part of the observations of part of your inspection. So these are all the things we're observing. You can observe your patient's positioning, whether or not they're assuming that tripod position, having to lean on something to promote lung expansion. Oftentimes, patients are going to have to do that. We even have some of our obese patients who are unable to lay completely flat, and that's because they suffer from orthopnea, meaning they can't lay flat, and they're having to sleep in recliners and things like that. So that's all of inspection.